case, I'll introduce you. Michael Mithoefer is an MD, a psychiatrist living in Asheville, North Carolina, with a research office in Charleston, South Carolina. He and his wife, Annie, conducted the first US phase 2 clinical trial of MDMA-assisted psychotherapy and subsequent phase 2 trials. They also conducted a study providing MDMA-assisted sessions for therapists who have completed the MAPS therapist training, and a pilot study treating couples with MDMA-assisted psychotherapy combined with cognitive behavioral conjoint therapy. He is a Groff-certified holotropic breathwork facilitator. He is trained in EMDR and internal family system therapy and has nearly 30 years experience treating trauma patients. Before going into psychiatry in 1991, he practiced emergency medicine for 10 years. He has been board certified in psychiatry, emergency medicine, and internal medicine, and is a fellow of the American Psychiatric Association and affiliated assistant professor at Department of Psychiatry and Behavioral Sciences in Medical University of South Carolina. It's a pleasure to have you with us talking about why psychotherapy with psychedelics, observations from 20 years of MDMA clinical trials. Thank you for joining us.
Thank you so much. I'm a little sad not to be there in person with all of you, and including some
Sorry,
dear.
Michael, but we cannot see your presentation if there is one.
I will share screen now.
Okay, thank you.
I hope. Can you see it now?
Yeah.
Is it full screen?
No, can you make it full screen, please?
Oh, yeah, okay. Oh, there it is.
Okay.
That didn't do it, did it? I don't think so.
No, it was okay.
Oh, was it?
Yeah,
okay.
It was.
How about that?
No, before
No?
it worked, yeah.
Okay.
Now, yes, perfect.
Okay, great. Okay, thanks. Well, yeah, as I was saying, I'm a bit sad not to be there in person, especially not getting to see some dear friends that I would like to be seeing right now. But I also am really grateful for the chance to speak and join you a little bit this way. So thank you. Yes, that's what I'm going to talk about, why psychotherapy with psychedelics. And these are just my observations from about 20 years of research with MDMA for PTSD. My disclosure is I received payment from Lykos Therapeutics as an independent consultant. I'm not speaking on their behalf today. These are my own opinions. And I want to remind you also that FDA at this point has not been approved by any US regulatory agency. So I'm talking about experience with clinical trials. And speaking of those trials, we started working on the first, we got approval for the first phase 2 clinical trial of MDMA-assisted therapy. These were all sponsored by MAPS. We got approval in 2001 from FDA. It took several more years to get DEA and Ethics Committee, IRB approval. And then over those years between 2004 and 2016, MAPS completed 6 phase 2 trials, leading to promising results that led to breakthrough therapy designation from FDA and also permission to move forward into phase 3 under special protocol assessment and agreement about the adequacy of the protocol. So that's what happened through MAPS Public Benefit Corporation and then Lykos. And now after completing 2 successful phase 3 trials, the new drug application was submitted and accepted in December. And so we're waiting for a decision. As you probably know, there was an advisory committee that was not favorable, but we still don't know what the FDA is going to decide. These are the papers about those 2 studies that were published in Nature Medicine, so you can read the details. I'm not going to speak about those except to say I want to remind you of the design of the trials, and this was very similar to the phase 2 design. And this was indicating that after informed consent, careful medical and psychological screening. People are enrolled, and then it starts with 3 therapy sessions, 3 90-minute preparatory sessions. And then the only times the MDMA is given is during, indicated by those squares, the larger squares, the darker squares. So MDMA is only given 3 times, about a month apart, in all-day sessions with 2 therapists. So there's a lot of therapy in that day. And then the small box afterwards indicate there are integration sessions after each one of those, more therapy that we think is important. So that's the way the studies are designed. Psilocybin is also on track to, has received breakthrough designation for 2 indications, and so they're moving along. I'm not experienced with that, so I'm not going to talk specifically about that, but my opinion is that much of what I'm going to say about what we've observed with MDMA, I think applies to studying many of these types of compounds. So here are 4 prominent issues I want to mention regarding psychedelic research and possible clinical use. One is that we have, these are being studied as investigated new drugs, but they also have a history, some of them thousands of years of history of use of humans, in MDMA, case of MDMA, some decades. So there's a lot of prior information, and then now we're doing modern clinical trials, which are also, of course, very important. So how do we take into account both of those things and not miss the chance to learn in different ways? Then there's the big issue of psychotherapy research is quite different from psychopharmacology research, and we're doing them at the same time in the same study. So that's a bit complicated. And then, you know, the third one is we're collecting quantitative data from validated measures. Meanwhile, the participants are kind of offering us an avalanche of qualitative data about their experiences and how important they seem to be to them. So what do we do with that? And then, of course, we're operating under the limitations of a very incomplete and problematic diagnostic system. So those are some of the issues I want to mention. I'll go around this wheel. So the first one, historical use of medicines compared to the value of modern clinical trials. This is a quote from Chris Bache's book, LSD and the Mind of the Universe, that I'd like to read. From ancient times, men and women have gathered together under the night sky and taken substances that help them commune with their inner being and with the life that runs through all things. They have sat in prayer and in silence, seeking healing and guidance so they could return to their lives better people and more aligned with the deeper currents of life. Because these substances opened them to the spiritual dimension of existence, they were called sacred. Because they healed the wound of forgetting who and what we truly are, they were called medicines. From before written history began, the sacred medicine path has been one of the many spiritual paths human beings have taken to find themselves, each other, and the divine. So we have that rich human history. And then we have, let's see, the FDA drug development system, which, you know, adds a lot in terms of scientific rigor. And it's an important way to study things. And also, it doesn't mean that there's nothing to be learned from what many cultures have observed in their approach to science. So I think we'd be foolish to think that we're you know, everything we're learning about this drug is new and everything in the past is irrelevant. So how do we square those two things? That's one of the areas of challenge, and I would say confusion often. So that's one of them. The next one is the inherent difference between psychotherapy research and drug development research. You know, this is some FDA guidance about the standards for drug development research. And as they point out, it's very important to distinguish drug effect from other spontaneous effects like placebo effect or or other influences like spontaneous change, placebo effect, or bias observation, we certainly don't want to be fooling ourselves. And normally that involves a control group, randomization, blinding, and replication. So, and in the same guidance, the FDA states that there are circumstances when they may rely on less certainty, they say, in some circumstances where this kind of design is not feasible or ethical. So they acknowledge that, and they also acknowledge that since their standards have not changed since 1998, and there's a need for more guidance about when it is okay to be flexible about design because of realistic issues of different kinds of studies. So there's that. And then there's standards for psychotherapy research, which are quite different because this is a recent paper. They're talking about the fact that they cannot use double blinding, and the treatments tested are composite treatment packages. So it's impossible, obviously it's impossible to keep a therapist unaware of what therapy they're delivering or practicing. And to complicate things further, the human mind comes into play. Elements like there are elements of human mind that are likely to influence the process and the outcome: consciousness, intentionality, subjectivity, agency. And as they say, as human beings possess agency, and as psychotherapies are collaborative work between patient and therapist characterized by responsiveness toward the other, and thus bi-directional effects, it is a misconception to label psychotherapy as an independent variable and patient symptoms as a dependent variable. So that's the state of affairs with psychotherapy research. And in this meta-analysis, they point out, there are thousands of clinical trials and hundreds of reviews, so it's incontrovertible that psychotherapy is an effective intervention across a wide range of problems. You can't deny that at this point, and you can't blind people in psychotherapy research. So they say replication functions as the final arbiter. So there you have it, the standards for psychotherapy research. If you look at the MDMA PTSD trials, MDMA assisted therapy for PTSD trials, the standards for psychotherapy research were met very well. The standards for drug development research were met quite well, I would say, but inherent to these kinds of medicines, there's a lot of functional unblinding as a challenge. So when do, as FDA says, when do they fairly and responsibly rely on designs that don't have all those features? So that's been part of the challenge and part of the confusion, because it's an unusual thing to be trying to study drugs and therapy at the same time. So then the next one is that I want to talk about is the qualitative data that comes along with the quantitative data. I mean, the qualitative data that comes along with the quantitative data. So here we are, diligently collecting the measures that we need that are important for our studies. In the PTSD trials, it was the CAPS-5, the clinician-administered PTSD scale. So as we're doing that, meanwhile, the participants are telling us all these rich experiences that they're having and how important they are to their process. So we're getting all this other information. Like this one veteran said, as interesting as the sessions are, I know from experience now that it's even more interesting what happens after the sessions when you're making connections. So he's talking about this ongoing process that's even more interesting after the drug is long gone from his system. So how do we take that into account when we're trying to figure out the effect of the drug and this treatment in general? This person talks about MDMA breaking this hard outer shell that kept them from engaging in other therapies and seeing the use of other therapies. So here they're saying this drug then helped me engage in psychotherapy in a way that I hadn't been able to afterwards. How do we take that into account? Similarly, this person talked about MDMA sessions are like a crack in the ice because the trauma was so solid and it took a long time to integrate. and it was confusing, but gradually I found that I could get back to that kind of state on my own. So there's a long process unfolding over weeks or months, maybe, about challenging and confusing process that gradually they were able to integrate, and it was very useful. So that's not on the, there's not a place in the caps for collecting that information. And this is a veteran that I'll talk a little bit more about later. It feels almost like the inner healer or the MDMA is like a maid doing spring cleaning. It's as if you thought you were cleaning before, but when you got the things you didn't really want to deal with, you just stick them in the attic. If you're going to clean the house, you can't skip the stuff in the attic. So, that sounds a lot like therapy. And this is, he's saying this after, during one of his integration sessions. So those are three of the sources of confusion. And then the other one I mentioned was the diagnostic system. It's very helpful in drug trials if you have a clearly identified disease, the pathophysiology, and you have an idea how the drug might be working. That's not really the case in psychiatric diagnosis. Going back to DSM in 1980, it was stated clearly there is no assumption that each mental disorder is a discrete entity with sharp boundaries between it and other mental disorders, as well as between it and no mental disorders. They also said it should be understood that for most of the categories, the diagnostic criteria are based on clinical judgment and have not been fully validated by data. Of course, in 1980, there was great hope that there would be, biomarkers would be identified and these would become actual identified diseases, but it hasn't happened. When DSM-5 came out, the biomarkers hadn't shown up, and it continues to be the case for most things that these are our best effort to organize what we're observing, but we haven't been able to identify actual diseases with clear targets. So that's the other confusion and challenge in this kind of research. So, and then there's the tomato effect. Excuse me. I think it says something that while in my medical training, I learned a lot about placebo effect, I didn't hear about the tomato effect until a couple of weeks ago. A friend, psychiatrist friend, Robert Strahan, sent me this paper by Goodwin and Goodwin about the tomato effect. And they start by explaining what the name means. Apparently, tomatoes are indigenous to the Americas, where they were thought to be poison. Meanwhile, they were imported to Europe, where they were found to be delicious food. And for years, no one in North or South America would eat a tomato because they believed them to be poison or bad. And so it made no sense to them to eat them. So it took a long time for them to even try it. So what they say is, these are quotes from the paper. While the placebo effect has contributed to the enthusiastic and widespread acceptance of therapies later shown to be useless or harmful, the tomato effect has stimulated the rejection or non-recognition of highly efficacious therapies. The tomato effect in medicine occurs when an efficacious treatment for a certain disease is ignored or rejected because it does not make sense in light of the accepted theories of the disease mechanism and drug action. There have been many therapies in the history of medicine that, while later proved highly efficacious, were at one time rejected because they did not make sense. Before we accept a treatment, we should ask, is this a placebo? And before we reject a treatment, we should ask, is this a tomato? So I really think we need to be asking ourselves that question about this treatment. So, just some of the things we observe that we don't know how to account for in terms of the drug effect. Just a sampling of those is one is the wide variation of individual subjective experiences that they reported in great detail. So very different experiences leading to similar outcomes on the quantitative measures. And the complexity and the progression of people's process that they describe is really important part of it in their opinion. So how does that fit in? We see regularly in the follow-up studies continued improvement over time. So even a year or several years after the last treatment, most people have lower symptoms than they did before. So it's hard to account for that in terms of drug effect. And in some cases, we see dramatic delayed responses a couple of months later. Something kind of clicks into place. So much that we don't understand in doing this research. So why have we spent so many years on research that's so challenging to do? Well, part of the reason is the burden of PTSD. We were seeing so many people with PTSD in our clinical practice, and we needed better treatments. As the World Health Organization says, half of global cases are persistent, and the disorder has been called a death sentence due to its association with increased risk of chronic disease, accelerated aging, and premature mortality. And that's in addition to the suffering of the PTSD itself and suicidality and all the relationship problems and those things. So, and we were faced with not a very good situation in terms of pharmacology. The only two drugs with PTSD indication still are Zoloft and Paxil with small to medium effect sizes. So they were not helping a lot of people. And as this paper says from this year, unfortunately, despite decades of work, the current drugs for treating psychiatric disorders and their overall efficacy are arguably no better, especially at improving functional outcomes, than the very first agents introduced well over 50 years ago. So we did not have a good situation in terms of pharmacology for helping many of the people with PTSD. But it had been recognized that actually psychotherapy, not pharmacology, is the definitive treatment for PTSD. But it doesn't work in at least half the people. So that's the idea of these studies, is finding out, could a drug like MDMA catalyze the therapy? So a much different way of using the drug. So that's what we've been doing, of course. And because there were also limitations in the therapy. Here's a recent paper, 2022, but the lead author is Paula Schnorr, the head of the National PTSD Center in the US, and she's comparing prolonged exposure with cognitive processing therapy. And you can see a clinical response defined as 10 points drop on the CAPS, achieved that in 60 to 73% of the time. 60 to 70% of the time still had the PTSD diagnosis after treatment, and only 12 to 20% were in remission. And this is in the setting of dropout rates of around half. So clearly, these can help some people, but there are a high proportion of people who needed something better in terms of therapy. So those were the reasons we decided it's hard to study, but it needs to be studied. So some observations supporting my opinion that psychotherapy can be very important in conjunction with these drugs. It's not a new idea. That's one thing. There can be a tendency for people to think that we just came up with these crazy ideas in using psychedelics, but this is not a new idea at all. These are just some of the papers I pulled up the other day about saying that psychotherapy and psychopharmacology work better when you do them together. This is a statement last week by Thomas Insel, former director of the National Institute of Mental Health, entitled, "Adding Psychotherapy to Drug Therapy Works, but the FDA may not be able to handle it." So as he points out, in contrast to most other medications, psychiatric medications confer change through experience. And he says this approach might be optimal to care, might be a path to optimal care, but it's challenging in the existing system because, as he says, in contrast to an antibiotic or a cardiovascular drug, which by themselves modify disease, the proposed effectiveness of MDMA was specifically linked to psychotherapy. He goes on to say, while considerable data demonstrate that the combination of medication and psychological treatment is better than either intervention alone, he's talking about the many other papers with other drugs, and he's saying, you know, we need a better regulatory process that addresses this innovation as a feature, not a bug of the treatment. So I think those are, I certainly agree with those statements. And then, you know, what about the biopsychosocial model? This is what I was taught in psychiatry training many years ago, and it's still taught today, I believe. The idea that psychiatric problems are a combination of biological, social, and psychological features. And this is a quote here from the original paper by Engel in 1977 about the need for a new medical model, a challenge for biomedicine. He said, the dominant model of disease today is biomedical, and it leaves no room within its framework for the social, psychological, and behavioral dimensions of illness. A biopsychosocial model is proposed that provides a blueprint for research, a framework for teaching, and a design for action in the real world of healthcare. So Engel was talking about this long ago, and it wasn't about psychedelics. And it's not passé now. This is, I'm sorry that somehow the date got taken off here, but or I left it off. But this is a recent book and talking about the accumulating psychosocial data that support this, vindicating Engel's proposal of a new model of medical medicine and healthcare to integrate biological, psychological, social factors. So leading to a much better understanding. So it's not just a passé idea. And interestingly, I also found a paper related to this about why the psychosocial model calls for good preparation of therapists. This is by Ronald Epstein at University of Rochester. And he's saying George Engel's biopsychosocial vision was simultaneously scientific and humanistic, and an approach to clinical care to correct the progressive distancing of clinical care and research from the lived experience of the patient. And he goes on to say, importantly, trainees and clinicians get stuck implementing the biopsychosocial model, partly because they have not developed the capacity for resilience, self-awareness, and self-monitoring. These capacities must accompany efforts to help clinicians engage more deeply with their patients. Otherwise, they risk emotional distress, empathic failure, premature closure, and withdrawal from effective connections with patients. This could be something we would say about our training for MDMA therapists, but this is not about MDMA therapists or any other psychedelic. These are observations about treating people with this awareness of the lived experience of the patient. And he talks more about building capacities of clinicians to become more self-aware and resilient and engage in compassionate action. So again, not a new idea. And, you know, as we got to getting ready for phase 3, we developed a robust training program for therapists. So the research therapists had training in this approach, and videotaped sessions had consultation or supervision based on the videos, and most of them had their own experience with MDMA in a therapeutic setting. We had a protocol for that. So that's the background of the preparation of the therapists the research, so we don't know what's going to happen post-approval, but I think we need to heed these words about the importance of preparing therapists for any kind of approach that really connects with people and takes into account the whole person rather than just handing them a drug. And another rationale for the importance of therapy, I would say, is, as Bessel van der Kolk says, healing happens in relationship. Traumatized human beings recover in the context of relationships. Recovery from trauma involves reconnecting with our fellow human beings. And here's an example from one of our sessions with a veteran in one of the phase 2 trials. So this was a time when he'd been lying back on the futon, just staring straight ahead for a long time, talking about trauma, but not looking at us, just staring straight ahead and talking about some really very challenging trauma. And so eventually we just wanted to check in with him, and Annie asked, "What are you noticing about the MDMA?" Annie, my wife and co-therapist, asked that. And he said, "It's allowing me to really view this part of my life that we're talking about in a new way than I have before, in a more complete way, and to understand it a bit better." And Annie said, "Are you feeling connected to us?" And he said, "Yeah, that's why I'm able to say these things. I don't think if I didn't feel connected to you, I'd be able to talk about these things." So that's his report of the importance of therapists, even at times when they don't appear to be doing anything. Here is a couple more quotes. "It was very difficult, but knowing that I had trust in both of you, I felt like it was worth it. I felt like you would be able to walk through hell with me." Another person said something similar. "When it was really rough, I knew you weren't going to leave me, and that made all the difference." So these are not trivial experiences. They can be very challenging, and a good therapeutic alliance in the presence of therapists can, by their report, can be very important. And this is also not a new idea. These are, again, papers that don't have to do with psychedelics, but this paper about the therapeutic alliance and the outcome of psychotherapy determines that, it concludes that the quality of the client-therapist alliance is a reliable predictor of positive clinical outcome, independent of the variety of psychotherapy approaches and outcome measures. This paper is about the role of therapeutic alliance on both psychotherapy and psychopharmacology, and they found that it to have a significant effect on the clinical outcome in both. So again, not a new idea, these are not about psychedelics. So it's not as strange as it may sound. And in terms of this, another thing that can be confusing about the approach to therapy is that we talk about a non-directive or self-directed or person-centered approach. But this is not new either. A lot of our training about it was with Stan Groff, a psychiatrist who was an LSD researcher. Here's what he says about it. "The task of the therapist is not to understand rationally the problem the client is facing in order to use some specific techniques to change the situation according to some preconceived plan, but rather to mediate and facilitate the client's access to a deeper state of the psyche." So that he was talking about what he learned, or at least partly from research with LSD, but others have talked about the same kind of thing having nothing to do with psychedelics. For instance, Carl Rogers, humanistic psychology or person-centered psychology, he talks about learning over the years, going from thinking, how can I treat or cure or change this person? And now I would phrase the question in this way: how can I provide a relationship which this person may use for his own personal growth? Very similar, but not about psychedelics. And this is a quote I've always liked from Irvin Yalom, a professor emeritus at Stanford, who wrote a lot of books about psychotherapy. And he said the therapist must strive to create a new therapy for each patient. And we would express it maybe a little differently and say, or maybe the therapist must strive to allow and encourage each patient to create a new therapy for themselves. But again, it's not a new idea. Many people have observed this phenomenon of the value of patient-centered care. It sounds a lot different from other therapy. I wrote this more than 10 years ago. It's in the MAPS bulletin. But the point I'm making there is that although we don't set out with an agenda to do a certain kind of therapy, these elements of other therapies that are well recognized tend to come up spontaneously, but in different order and different degree for each person. So people end up doing imaginal exposure and notice cognitive distortions and work with transference and do psychodynamic work, notice things in the body, notice multiplicity of the psyche. It seems to help corrective attachment experience, and there's often very interesting imagery. So all that happens. It's not just like a entirely different thing than other trauma therapy. It's just that it happens with flexibility and according to a given person's own process. So this is a paper by Ramakara Harris's lab about beginning to look into this idea of the inner healing intelligence that guides these processes. And they're saying basically there's a lot to learn, but it looks like it supports the construct being a substantive phenomenon. So more to learn in that way. But this picture I put up because I want to make the point that the reason we think that we're not it's good to not be so directive is because we see people taking unexpected paths very often. So a good therapist with good training that has an agenda to do a certain kind of therapy and goes down one road by intention will probably do something helpful. But we think that with these types of compounds, if you aren't too directive, there's an opportunity for something unexpected that may be particularly useful. So how am I doing on time? I have one short example. It's not a video, but just an example of one case, or am I out of time?
Michael, you have 5 more minutes, including Q&A.
Well, do you want to go straight to Q&A then? It seems a shame not to have a little time for that.
Okay. Yeah. Okay. So maybe the people who would like to have to ask a question, maybe raise your hand so we get a feel of how many. Yeah, we do have some questions here. So please, you can just go to this microphone. Yeah. Can you hear them?
Yeah. Yeah, it's nice to be able to see the room. At least I have a feeling I'm speaking to people.
Thank you. Ronit Kishan from Columbia University, from the New York State Psychiatric Institute, a clinical psychologist, and I a principal investigator with studies that have to do with psilocybin. First of all, I wanted to express to you my deepest gratitude to you and your wife, because to be part of conventional structured psychiatry and at the same time to be able to hold those views and be your own individual, have such an individual way of looking at things, I think is not prevalent at all. So thank you for that. It's very inspiring.
Thank you very much.
The point you're making is excellent. And I think I always say that these plants actually also came to dose our science, right? And to dose us researchers. Kind of, I mean, the whole dichotomy between brain and mind, I'm not sure that's the real story, and I won't get into it. But I wonder if you have any thoughts, because in a way, we might end up being, instead of integrating and emphasizing to psychiatrists and psychologists that there is a lot more that needs to be integrated, we are kind of becoming our own group, right? We are the psychedelic research and therapy, and we are kind of creating our own community, which has many benefits but we might be just another group, if you know what I'm trying to say. Well, I think the message that we hold, based on what you're saying, is that there are many more similarities. I mean, I'm also Israeli, and I happen to had my internship or externship at Ramat Chen, which is a very known place, which many years ago was very humanitarian, and we used to hug patients, and they still remembered it after years. So how do we maintain our own voice, and at the same time we keep pointing to everyone else that there is a lot to learn here, even if you don't want to do psychedelic stuff? I hope my question is clear enough.
Thank you. Yeah, it's very thoughtful. Yeah, I don't know. I think that's a big challenge. As we now, if these drugs are going to be approved, which may happen fairly soon, how do we integrate it in the system without either breaking the system or breaking the real heart and meaning of this type of approach? So I think recognizing common factors, realizing any experienced trauma therapist will recognize the kind of things that are happening in the session. And it is a new approach not to have to control it and have such an agenda. So I have concerns in both directions that either it'll seem so strange it'll be rejected, or that it'll seem, oh, kind of like the same thing, just a drug that makes it a little easier, and miss a chance to really learn it's quite different. There are important similarities and it's not all new, but we don't want to lose sight of that. We need to make some real changes in how we approach treating people. I hope it doesn't sound snarky, but sometimes I said, trying to figure out how to fit this type of treatment into the existing medical system of, short appointments and things seems a little like if you discovered penicillin, then trying to figure out how to get leeches to deliver the penicillin, instead of realizing, oh, we don't need the leeches anymore. This is something different. So
Yeah, I want to give opportunity for other questions, but I actually think you
Sorry, we don't have more time. I'm sorry, we don't have more time for more questions at all, because we have a postal session now. Michael, I want to thank you deeply. This overview was very informative, interesting. Thank you so much for joining us.
thank you so much for inviting me. Take care.